Want me to start with?
Oh, I got you. I'll intro everybody. Welcome, folks, to yet another episode of Thursday Virtual Morning Report. It's a special treat in many ways, but the two most prominent ways are I will hold back for a moment and actually hand the mic to the people who are making this happen. The first is Simi, who has her beautiful interview background decorated. Hi, Simi. Good morning.
Hello, good morning, everyone. Very excited to scribe today and excited for Pawandeep's case and discussion by Sam. So looking forward to the session and welcome Pawandeep. So happy to have you here.
Amazing. One secret has been slowly revealed. We'll zoom in on that in a little moment. The other secret will be hidden unless Gerardo decides to reveal it too. Gerardo, Mike, to you. Thank you for doing teaching points today.
Yeah, hello everybody. Good morning. Yeah, I'm excited to hear today's case and do the teaching points. And yeah,
Wonderful. It's so nice to see you, Gerardo. Yeah, we have a special treat. I think it's a first for two folks. Sam is joining the lukewarm discussant seat, and for those of you who don't know Sam, she burst onto the scene on CP Solvers literally. I still remember the text message that I got from Dr. Ravi when she presented a case of a hypertensive patient in the emergency room who had an unbelievable diagnosis. And I think her explosive onset has been met with a continued proportional impact on CP solvers, culminating in her first ever rapid fire internal session yesterday that she presented to see me, which was unreal and I think really illustrative of the doctor she is becoming. And I'm very, very excited to celebrate that by by doing none other than what we love the most, which is to discuss the unknown case together. Let me hand the mic to you to Sam to say hello.
Yeah, good morning, everyone. I'm so excited to be here. Thank you for that glowing introduction, Dr. Ravi. Very excited to discuss with you today, learn with you. I'm very excited to welcome Pavandeep, presenting your first case. I'm so excited to hear what you have in store. For anyone who hasn't met me yet, I'm a fourth year med student up in beautiful Portland, Maine, and I'm going to be an emergency room doctor. So um, but I love discussing, things, any body system, any kind of pathology, because it all comes through our door. So I'm very, very
Yeah.
excited to learn today.
Indeed, yeah, I think it's a pretty rare circumstance for an ER doctor to be interested in kind of taking the diagnostic journey to the end. But I will tell you, I think as somebody who also works in the emergency room, I think uh, it's so crucial to have a sense of where the cases that come through our door go. And more often than not, I would say a really, really good ER has at least a sense of where a case is headed, even if it's headed towards sarcoid. It's totally, totally okay. But yes, you're right. We have our first time case presenter, Pavandeep. Maybe we can ask you to unmute and tell us a little bit about yourself if you don't mind.
Hello, everyone. So yeah, my name's Pavandeep. I'm an internal medicine trainee at a London-based hospital. Yeah, and I'm excited to present my first case. Hopefully it goes well. And hopefully I do justice to this platform.
Yeah, we're very, very glad to have you here for the first time. How did you come across this space?
I wish I could tell exactly how, but I don't remember myself. I think I'm probably just like scouring the internet
Uh-huh.
after looking after like a patient and not knowing what was going on. And then yeah, I sort of stumbled across here, and I'm glad I did.
Yes, likewise. We're glad that you're here. What do you like to do outside of medicine?
Well, when we do get time off, mostly recovering. But yeah, like hiking is something I'm really enjoying.
Hmm.
We're quite lucky in the UK. We've got quite a few scenic landscapes,
Yeah.
but not so lucky with the weather. So when the weather is good, hiking's a nice thing to do, but also just reading as well and spending time with friends and family.
It's such a wonderful mix of surrounding yourself by people you care about, the indoors of the reading and the outdoors with hiking, though you may combine all those things in one fell swoop, as I like to do sometimes. Though you would never catch me reading a book. I don't have the attention span to read a book. I just, yeah, I need to know fast, which is why I think Sam and I will get along great this next hour. Classic ER mentality. But why don't we hand you the mic and we'll go ahead and get started with the case.
Perfect. So I think I have six aliquots in total. So I'll start with the first one. So we have a 70-year-old gentleman.
who's presenting to the emergency department with shortness of breath. A few months ago, it was on minimal exertion, but now it's at rest and associated with palpitations. And that's the end of the first aliquot.
Oh, beautifully presented. Thank you. And for outlining how many aliquots are coming our way. That's very helpful. Yes, Sam, what's crossing your mind?
Yeah, so an elderly gentleman, I would call this a chronic progressive shortness of breath. So initially with minimal exertion, now it's getting worse and worse. It's occurring with rest. And now he's having these palpitations. So I think if I'm the first person seeing this patient in the ED, I think my eyeball exam is going to be the most helpful thing. What does he look like? Is he all sweaty and he is in acute distress? Or is he just kind of sitting there and he's resting? That's going to change how I approach this case quite a bit. But I think given what we have, I think in a 70-year-old, I'm going to start with the common things that can cause progressive shortness of breath and palpitations. AFib is going to be a huge thing to assess for, whether it's been paroxysmal in the past or if this is a new presentation of AFib. Heart failure, certainly. Now on rest and with palpitations, the most serious things that can cause shortness of breath in the emergency department, things like pulmonary embolism, aortic dissection. I'm not really hearing that he has a lot of pain. So I'm a little less concerned about something very acutely life-threatening if he's been walking around for a few months with this. But he could have some sort of underlying pulmonary pathology. Maybe he's more susceptible to an infection. He's contracted a pneumonia and is progressing to sepsis. There's really so much that could be going on here. Oh yeah, and then I see anemia in the chat. I love anemia, very common, causes a lot of systemic symptoms, certainly a great thought. And then other than AFib, I mean, there's a lot of other dysrhythmias that this patient could be having. Perhaps he has some chronic ischemia that's causing some conduction abnormalities in the heart that are giving him these palpitations and shortness of breath. So I think that's where I would start. What are your thoughts, Rabih?
Yeah, I think Sam, like you, it's such a broad differential diagnosis of what can cause shortness of breath. And if you were to have a first year medical student with you shadowing you, you'd ultimately have to overwhelm them with information because what shortness of breath fundamentally is like there's something wrong in the chest, right? And so I love what you did at a deeper level, which is you're like, let me use the palpitations to my advantage and use that kind of went into like a differential diagnosis of how that influences your calculus. But then I heard you kind of be like, okay, yeah, cool, that could be what's going on, but let me zoom back out and make sure that I'm not missing something. And I think that reflects subconsciously that you've uploaded that the value of palpitations is plus minus, that it doesn't lock you into a specific differential diagnosis. And here's the reason why. You can feel palpitations because you have a dysrhythmia, as you so aptly said, but you can also feel palpitations just from the hypercontractility associated with a high adrenergic tone. It's maybe the most emphatic way I can make this land for all of you who are incorporating this as a new concept is how many patients with panic disorder will tell you that they have palpitations, but their EKG shows sinus tachycardia. And that's because the hypercontractility really, really can be felt by people. And I will tell you, as soon as I finish a run, I'm more in tune with my body and I'm not kind of like relaxed from jogging. And I feel palpitations for the last 30 seconds or so. So the question here is, do palpitations represent a dysrhythmia, as you aptly said, or do they represent actually just a hypercontractile state, in which case they lose their diagnostic value because they're just meaning the patient's stressed in some way, shape, or form, physiologically or psychiatrically. So I think, like you, the differential diagnosis has to be broad, and I think it's more profoundly influenced by the time course, the fact that this is a smoldering shortness of breath rather than an abrupt one. So as an example, it's hard pressed to fit aortic dissection in a situation where somebody's been feeling this for quite some time. So as you saw Sam do, use the palpitations to your advantage, but remain broad. Don't get locked into them because they may just mean that the heart is hypercontractile rather than beating funny. Awesome. How about you, Mike, to you?
Perfect. That's great. So prior to this attendance, he actually presented to ED quite a few times in a span of a few months due to his shortness of breath. but he also reported a few other symptoms. So you mentioned I have vomiting, occasionally I get diarrhea, and he also in passing said, I've had quite a pronounced weight loss over the past 3 months. He then goes and mentioned that for the past 4 to 6 weeks, he's been bedbound because of these symptoms. And I just want to note that in the ED clerking, the clinician noted that the patient looked a bit pale. And during all these admissions prior to the most recent one, he's been discharged home. So he's actually never been admitted. On the most recent ED, he presented with shortness of breath. He was given 1 unit of red blood cells and then sent home. So now I want you to fast forward a little bit. So this is when I get to see this patient. He's been to ED multiple times, but now 2.5 months later, from his most recent ED presentation, he's actually being admitted electively onto my gastroenterology ward due to a colonoscopy. And he was asked to come in by the colorectal team to have this done. And that's the end of that aliquot.
I just want to call, I think Sam's going to inhale this aliquot and analyze it so well. I just want to call attention to the clarity of your presentation, Pamandeep, and the emphasis on the sequence of events. And I think you, like many people who are as skilled as you are, may take it for granted. This is sort of your norm. But I will tell you, as somebody who's been living in the world of medical education for a decade now, this tells me so much about how you structure your own knowledge and how you care for patients and how you've consolidated this information. So thank you for laying it out so clearly. Sam, what are your thoughts?
Oh, I have so many thoughts and none of them are good, Dr. Rabih. I'm scared. I'm very worried about this patient. Because, progressive shortness of breath, palpitations, I can see the road where that patient gets discharged. But now you're adding vomiting, diarrhea, weight loss. So now we have essentially this is a full body systemic disease. This is not just a chest problem. And I don't know if I'm jumping ahead a little, Pavandeep, but he's bedbound from these symptoms. What was his prior functional status like?
Independent with all activities and tasks at home.
Oh dear. Okay, yeah. So I'm very concerned that the symptoms have progressed to this point over the last few weeks where this patient who was fully independent is now bedbound. That is a huge red flag. I'm shocked that he hasn't been admitted prior to this. I certainly would have tried to have gotten him admitted before it got to this point. Of course, hindsight being 2020. But that's a huge concern and something I try to ask patients when they're in the ED is how much is this really affecting your life? And this is very concerning to me. So trying to think diagnostically, we have the shortness of breath and palpitations, nausea, vomiting, and diarrhea, weight loss. The way that I would sort of try to, if we could tie this all together, the weight loss is concerning for a few things. A malignancy is certainly high on my differential in a patient in this age group. And there are, I believe, some GI tumors, and somebody who has just gone through this a few more times will remember exactly what I'm thinking of, I think. But there are a few GI tumors that can, I believe, secrete things that make you hyperadrenergic or hyperserotonergic, cause sort of increased tone, can cause palpitations, weight loss, things like that. Yes, carcinoid. Thank you, Sasan. That could be a concern. And then if he's received transfusions as well in the past, whatever is going on is making him significantly anemic. So whether that's due to an inflammatory process, so malignancy could be causing inflammation, or he could have some other inflammatory condition going on, or the problem itself is causing him to bleed. So either he has additionally friable colonic mucosa, something like an inflammatory bowel disease, or some sort of GI malignancy, I think are my top concerns at this point.
Yeah, Sam, I'm right there with you. And I just want to make it a really powerful, I want to emphasize something that's really powerful that you just did, which is that you emphasize that this is not just anemia, this is anemia requiring transfusions. And I think that label is probably analogous to the situation of acute liver injury versus acute liver failure. Now, I will tell you that most acute liver injury is a condition that you can discharge patients from the ER because they don't have any consequences of it, and you can often treat their condition by stopping the offending drug, or by treating the offending infectious hepatitis, and they don't need to be admitted. And the same is true for anemia. If somebody has anemia, it's often either non-specific as a consequence of inflammation or has a specific mechanism. But you can safely discharge a patient, just like acute liver injury. But the failure analogy is when you need to intervene. And when you need to intervene by saying that if I don't give you blood, you're going to suffer serious consequences, this is a failure of the hematological system. And any failure diagnosis is one that must be taken seriously. And the prevalence of a non-specific uh, explanation for anemia requiring transfusion, i.e., anemia of chronic inflammation, is basically zero. Anemia of chronic disease rarely results in a hemoglobin that requires transfusion. So not only have you diagnosed this patient with hematological failure requiring you to intervene, you also have a tremendous confidence that there is a specific mechanism that is accounting for this patient's anemia, diluting the probability that they have actually an anemia in response to a non-specific condition. And so it's interesting that we don't know the details of anemia, but it's interesting that that this has routed the patient towards GI. And I will share a word of caution about that. The first is that this must mean that the patient's anemia is presumed to be iron deficiency. And that's a very wise presumption for us to make because it's actually a presumption based in base rate. And it's a presumption based in his GI symptoms. But I will tell you one way that this could go wrong is that the referral to GI is a presumptive one based on base rate, and the patient's iron studies are actually completely normal. And so this is one way where I think the workup and evaluation for anemia uh, often goes astray, is we think anemia in an older adult has to have a gastrointestinal loss, but the mechanism by which that is happening is through iron deficiency. So if we later learn that actually his iron profile is completely normal, then we're like, wait, is this MDS? Is this like multiple myeloma, so on and so forth. So what I'm really anxious for now is I know the anemia has to be explained in a very specific way because it's requiring transfusions. And I'm really glad that he's in the hands of people who can exonerate and evaluate the most common cause, iron deficiency. But I want to make sure that that's the pathway for most people, but it may not be the pathway for him. And one simple test can help us breathe. It's what is his serum ferritin and what's his percent SAT? Otherwise, he's in great hands, getting a great test, and we'll see how this plays out. Mike to you, Pavandeep.
Perfect. So I'm so impressive that you're rattling through quite a few thoughts there. So review your symptoms. So yeah, similar symptoms I mentioned as before, but he denies any chest pain, no abdominal pain, there's no cough, there's no change in his sensorium, no cognitive impairment that he mentions. His bladder and bowel symptoms, there's none. No obvious bleeding. He denies any night sweats, but he does say to me that, oh, I'm not eating as much like I used to, but I just don't have the appetite anymore. No skin changes, no ENT symptoms. So moving on to his past medical history, he's actually regularly seeing a hematologist and he was referred to them by his GP, so his primary care physician, in 2019. And the reason being is because he had this persistent macrocytosis on his bloods. So he's been seeing the hematologist from 2019 until current time of 2024. And the hematologist has done a thorough workup. So that includes his thyroid, B12, folate, the myeloma screen, LDH, DAT, and all that came back negative in 2019. And so he's just being monitored right now. I'm going to paste his trend of blood results in the chat, so because it's quite extensive. So I think I'm going to send that to Simi and she can paste it on her sheet. But you can see the trends are coming down for a few bloodlines and a few other things. In terms of other past medical history, he has OA, he's had a knee and hip replacement, severe migraines, depression. He had a septal stroke in 2015. He's got residual visual field disturbance and atrial fibrillation as well. In terms of his medication, let me know if I need to slow down for you to catch up. But he has allopurinol, vitamin D, atorvastatin, bisoprolol, promethazine, riroxaban, sumatriptan, cocodamol. So nothing too exciting there. In terms of his family history, nothing, not that he can recall. In terms of his social history, he lives alone on a first floor flat. He was independent, but now is bedbound. He hasn't got any package of care, so no private carers coming in to help him. So he scores a clinical frailty score of 4, which means he's vulnerable. He used to work as an engineer, but he's now retired for many, many years. In terms of his health-related behaviors, ex-drinker, he said it was only socially. And he can't remember the actual units, but he says it's mild to moderate. And he's an ex-social smoker, and he only smoked tobacco. There's no other social history, and he hasn't got any drug allergies either. So that ends my third aliquot.
Oh, I feel like I've said this plenty, but I think you should take a look at the chat as to people's comments about how you're bringing this patient to life in our minds. Thank you so much, Pawandeep. Yeah, Sam, I'm curious to ask you, part of the ER job is sort of triaging information coming your way. You just heard a lot of things. I'm curious, what do you think influenced your calculus? Of all the data you got, which one is taking up the most space in your brain?
Of everything we've gotten so far, the progression from fully independent to bedbound is the scariest thing
Awesome.
to
Super.
me.
Yeah, agree.
That's huge and it just points you in such a clear direction of this is a very serious illness.
Yeah.
This is not going to get better on its own without our help.
Beautiful. And what do you think is the most specific clue that you got to solving this very serious problem? Now, you've identified the problem is very serious. What do you think is living largest in your mind as to the most sort of specific uh, piece of information to help you crack this case so far?
So far, I think it's the reduced appetite and weight loss is really jumping out at me. Just really pointing me to some sort of multi-system,
Yeah.
systemic, inflammatory etiology of this patient's symptoms.
I'm right there with you. I think the loss of complete loss of functional status and the severity of the weight loss are really loud alarm bells, and they're like sinus tack. I think the problem with them, unfortunately, is that they don't give you a sense of where to go. If you ask yourself, like, what is the DDX of those things? None of them are benign, but it's still a very long list. So for me, what helps me try to say, okay, I got a long list, but what's zooming in is now we got a long-standing macrocytic anemia for years preceding this. So
Yeah, and
how you
I was
yeah,
grateful
sorry.
that
Yeah.
I was grateful, Pavandeep, that you told us his B12 has been persistently normal, because that was the first thing I thought about was, well, B12 deficiency could cause any of this. But that takes a very common diagnosis almost off the table. I'm still going to repeat it, but it's helpful.
Yeah, I'm curious we're going to examine him, as you said. You want to lay eyes on him from the very beginning and see why he's short of breath, and we'll definitely do that because he may have true and unrelated shortness of breath. But what do you think, based on this information, what do you think you might get going in the ER in terms of tests?
In the ER, certainly a CBC. I need to see his hemoglobin. I need to see his white count. I need to see his platelets. Ferritin, absolutely. Iron studies are percent sat. I think an ESR and a CRP is reasonable as well at this point, as well as an EKG and at least a chest X-ray. But maybe my physical exam would point me towards needing more advanced imaging, like a CT scan with or without contrast. And then really depending on, I mean, I think a stool guaiac test is also not unreasonable in this patient if we can get one.
Yeah. Yeah, awesome. Do you think you'd get a type in screen from the get-go, or do you think you'd wait for the
Yeah,
hemoglobin to come
I'd
back?
absolutely get a type in screen. I'm not waiting.
Yeah, there you go. Yeah, big piece of it. When somebody's coming in with shortness of breath who has a history of anemia for 2019, get that type in screen and maybe even consent the patient before the hemoglobin's back so you're ready to move. Yeah, no, I think
Absolutely.
that's a very, very wise workup. I'll share that the macrocytosis here is really, really important because Um, Macrocytosis often means one of two things. The first is it means that the patient may have a metabolic derangement like liver disease, kidney disease, or thyroid disease. But those are usually very obvious. You don't need a macrocytosis to be like, oh, I think this patient has an AST of 500 or a creatinine of 5 or a TSH of 100. You don't need that. So you really ask yourself, like, when is macrocytosis a mystery? It's often when a patient has a nutritional deficiency or an intrinsic problem with their bone marrow. And there's something wrong with their ability to take a very large cell, which is your precursor cell, and kind of compact it. Um, and so, Sam, when we think about a persistent macrocytic anemia without evidence of liver disease, kidney disease, or thyroid disease, I think nutritional deficiency, as you just emphasized again, is probably looms large on our mind. But most, not all, most nutritional deficiency or deficiencies are readily assessed by a simple workup of B12 folate, as you emphasized. So for me, part of what I'm wondering is this a sneaky nutritional deficiency, or is this patient actually have a bone marrow issue? And the reason the cells are so big is because there's a failure in the marrow to make them nice and tight and compact.
Yeah, I
So
love that thought. Like, does he
yeah,
have a copper or zinc
yeah,
deficiency? The other thing I was thinking about was a reticulocytosis, but
yeah,
I would hope that the hematologist would have assessed for that already.
yeah,
And having a persistent reticulocytosis for years
yeah.
without then transitioning to a microcytic anemia would be very, I think, unusual in my mind.
I completely agree. Yeah, so I think if we go back to that kind of initial situation of he's got an anemia requiring transfusion, this is a hematological failure. The most common cause is iron deficiency. Ah, that could be a good reason to send him to GI. What do you think about the decision that what do you think about the thought that he's in GI clinic now? Are you glad he's there or are you concerned it's the wrong place?
I'm a little concerned it's the wrong place. Just with my own experience consulting GI from the emergency department,
Yeah,
they really don't like unstable patients. And this patient may be stable right now. I don't have the rest of his vitals, but he certainly could decompensate very quickly. And then I'm concerned that GI clinic is um, not going to be the right place to manage giving him a transfusion,
yeah,
possibly needing to volume resuscitate him or cardiac resuscitate him
yeah,
should such a thing happen. I
yeah.
want him on telemetry, obviously, with the everything. So I'm a little concerned that GI clinic might not quite be his
Yeah.
ultimate home. I would love him to be at least probably intermediate care, if not the ICU.
Yeah, I agree with you. I think that the fact that his symptoms are dynamic, especially progressing over the last few weeks, is a very concerning. And I think in order for a safe endoscopic procedure, you need to temper that as much as you're able to do so. And from that element, I would definitely be concerned and try to sort of stabilize him before doing so. I'd also say that a persistent macrocytic anemia often means the problems in the bone marrow, unless it's a nutritional deficiency. So I would hate for a patient to get a EGD and colonoscopy for a nutritional deficiency that can be diagnosed through other means. So I'm really intrigued to be like, is this the manifestation of a very common misstep where you think that a progressive anemia should always have an EGD colo, or is there something unique about this patient's case that actually labels this as a progressive macrocytic anemia with additional gastrointestinal components? And that is a very unique and very interesting space to reflect on. So I think for me, I'm holding my breath till we hear those iron studies, because if they are low, iron deficiency plus a progressive macrocytic anemia is a very, very interesting problem to solve. If they are not low, then we'll have to chat with our GI colleagues and say, huh, what's going on here? What value are we hoping to bring to this patient? It might be because he has IBD and he has ileitis, and ileitis has caused a B12 deficiency, and that's why he's at a progressive. So there's many creative ways to do so. But I will tell you, when I'm hearing this case, I'm like, GI ward, and I'm intrigued. Tell me more. So, Pavandeep, tell us more, please.
Um, it's great, all your thoughts. Being the NHS, we wish we could order as many things as we can, but sometimes we are reluctant with our financial expenditure. But just to segue into the comment about stable macrocytosis, and it's not actually part of my aliquot, but I think it's quite useful from the hematology consultant actually saw him in 2019. And he says, a stable macrocytosis Once secondary causes are ruled out with an intact blood count, otherwise rarely requires further investigation, but may represent a congenital dyserythropoietic anemia or very early myelodysplastic syndrome, which, by definition, has not progressed since it has been monitored now for the 5 years, albeit only scrutinized at this point. So that's just his impression, and that's where he was up to in terms of the investigation workup. But going back to our Aliquot now. So yeah, I'm going to see this patient. So in terms of his vitals, he's afebrile, heart rate's 96, blood pressure's slightly on the higher side, 156/72. Resp rate is 18. He's saturating nicely at 98% on room air, and he's using a 1, which is basically just an early warning score for our patients on the ward. In terms of how he generally looks, he's alert. He's orientated to time, pace, and person. At the end of the bed, there's no profound cachexia, but he looks a bit pale to me. There's no bruising. There's scattered seborrheic keratosis on his face and back. There is conjunctival pallor, but there's no angular chelosis. There's no obvious cervical lymphadenopathy. It's quite dark in our bay, but I think his nails look a bit pale to me. In terms of his cardiovascular exam, his heart sounds are normal. There seems to be a soft ESM in the mitral area, I think. Pulmonary, it's clear anteriorly, equal air entry bilaterally. In terms of his abdomen, it's soft, non-distended. There's no organomegaly that I can appreciate on palpation. Bowel sounds are present. Neurologically wise, grossly normal, and there's no focal bony tenderness. So that's his examination. In terms of his bloods that I did at that time, it's quite extensive, but I'll just rattle through them, and I've copy and pasted it into the chats for Seema to put in as well. So his hemoglobin now is 48, and in terms of our labs and our UK standard results, the lower range is 133, so his is 48. His MCV is 105, highest range is 96. Reticulocyte is 23.5, which is low, and for our range, it's 50 is the lowest. His white blood cell count is 5.1, and that's normal. His platelets is 10. Low is 150. His monocytes are high, 1.8. Highest is 0.8. His lymphocytes is 1, that's low. His immature platelet fraction is 15.2%. High is 6%. His PT and his APTT are all normal. His INR is 1.3. His urea and electrolytes are all normal. His ALP, so we're now moving on to his liver function. So his ALP is 212, and that's high. The highest for us is 130. His ALT is 19, and that's normal. His bilirubin is 26. That's only marginally high for us. Our high is 21. His calcium, this is corrected calcium, is 2.14. That's low. Low for us is 2.2. His CRP is 64. And sorry, I forgot to mention his neutrophils is 1.2, and low for us is 2. And that's all we did so far. So there's no iron studies yet. But that's the end of my 4th aliquot.
Pamani, this is absolutely amazing. And the fact that you are making it easier for us by normalizing your units is greatly appreciated. Sam, I think this is a pretty good time to do a little bit of breakout rooms and mix our thoughts together, because I think this case has so many abnormalities. How does that sound to you?
Sounds good. And I just want to applaud Pavandeep for giving us such a good nutritional exam. Thinking about angular,
Yeah.
problem like looking in the mouth, looking in the eyes. It was so thorough and so clear. So I appreciate that very much.
All right. I'll see you all in a few minutes, okay? All right, welcome back, everyone. So Sam, what are you and your group's thoughts?
Yes, our wonderful group. I believe we're at this point quite eager to see the iron studies and probably a bone marrow biopsy is where we think that this is going to end up. This is a patient with pancytopenia, impaired reticulocytes. And
Yeah.
then we talked a bit about the platelets. The percent of immature platelets being up shows us the bone marrow is doing something, but with the absolute number of platelets being so low, he still has a depressed number of immature platelets. So there's probably like, this is all a bone marrow problem. He's neutropenic. He has excessive monocytes. So I'm concerned about something in that cell line, possibly being neoplastic or dysplastic. Other things to think about would be getting the viral studies that we need in a pancytopenic patient, whether because these can predispose people to a myelodysplastic syndrome, or if this patient ends up needing some sort of further treatment, we'll need to know if they are positive for EBV, CMV, HIV, hepatitis, parvovirus, I believe, is also one of the ones to think about, as far as things that can either cause or predispose you to bone marrow failure, or that you need to be concerned about in an immunosuppressed patient.
Not only are you analyzing the elements of the CBC so well, you're also anticipating what this patient's future like in a manner that I think is far, far in excess of what you will need to do next year in the ER. And I think going above and beyond is the call of this profession, and I really admire that you're doing that. If I were to sort of distill the elements of the CBC, I think you hit on all of them. You hit on the dysplasia vibe that you're getting. And I think we've talked a little bit about how a progressive macrocytic anemia without a clear cause certainly invokes the idea of a myelodysplastic syndrome. And I think the further support that you have for that is that there is consequences on the white blood cells and the platelets. And the consequences on the platelets are profound. The platelet count is 10, but a little confusing because you're also seeing that there is a lot of immature platelets in the periphery. And I think it's a very simplistic model to say that immature platelets is a physiological response to the platelets being consumed. But unfortunately, sometimes immature platelets in the periphery can mean that they're being forced out prematurely by something in the bone marrow. And that hypothesis is supported by the fact that there is abnormalities in the red blood cell line, but also the white blood cell line. And seeing that this patient's neutrophils account for a small fraction of his total count should be a largely alarming thing because it represents a serious dysregulation. So on the surface, this patient has a normal white count, an anemia, and a thrombocytopenia. But as you aptly said, he has major abnormalities in all three cell lines, which are evocative of a bone marrow disorder. And the kind of bone marrow disorder he has is also perplexing because, as you said, he has dysplasia, with the macrocytosis being the most powerful hint, but he also has cytoses. And so you have three things that are almost paradoxical. You have low platelet counts, you have low neutrophils, you have a hint of dysplasia, so you've got cytopenias, dysplasia, and you have a cytosis, and that's the monocytosis. And for me, I really worry about what that monocytosis represents because it right now doesn't meet uh, any profound criteria because it's not persistent. Monocytosis is often a noisy thing that comes and goes, but if this is persistent, which there's reason to believe it would raise the possibility of a set of syndromes that actually bridge dysplasia, cytopenias, and other things, and that's the myelomonocytic diseases, namely chronic myelomonocytic leukemia. And the reason that's on my mind too, just to speed things up, is because of the alk phos. So the monocytic disorders have a tendency to infiltrate. And so, Sam, when you see somebody who comes into the emergency room with gingival hyperplasia and who's sick, one of the thoughts that might cross your mind is, are they sick and have gingival hyperplasia because they have a monocytic leukemia? And that's an emergency for us in the ED. And this patient doesn't have gingival hyperplasia, i.e. infiltration into his gums, but he seems like he might have hepatic infiltration with an isolated elevation in his alkaline phosphatase. So long story short, I'm right there with you. I'm really, really worried about this patient, and I think the answer will come from the bone marrow. I'm really curious how the GI doctors are analyzing this data and really curious what the iron studies show, but I would suspect that with this setup, you'll actually see iron overload. And the reason the iron accumulates is because the marrow can't use it. So you have all this iron that's lying around and it just is just wasting away. So really, really curious to see what that result is. But yeah, awesome job. This is a marrow issue, and the kind of marrow issue is not super important for a generalist to figure out. But whenever it's confusing, dysplasia, cytosis, cytopenia, it often represents an overlap disorder of myeloproliferative and dysplastic features, which CMML is a classic example of. All right, Pamandeep, what do you have next?
Amazing discussions. Thank you so much. So if things weren't complicated already, this patient then decided to spike a fever for us. And we did a whole workup for this. So we sent off blood cultures, did viral swabs, they were all normal. We did a chest x-ray. So he has enlarged heart with perihilar haziness associated with bilateral pleural effusions, and the radiologist goes with likely heart failure. But his troponin was normal, his BNP was normal as well. We sent a urine MCS and that was bland. We also noted that he had swelling of his right arm, so we did an ultrasound Doppler for it. And the report was no evidence of DVT, SVT, normal arterial Doppler flow. There's some sort of mild subcutaneous tissue edema. And there's also evidence of multiple non-vascular mass present lying anteriorly to the subclavian vessels, query malignancy. And at this time, we did do iron studies as well. So iron was 20, unsaturated iron binding capacity was 13, iron saturation 61, ferritin was in the 1000s. His folate was normal, B12 normal. Total iron binding capacity was 33, and that's normal. And so in view of these masses that the radiographer picked up on, we also sent cancer markers as well. So we did send off the AFP, and that's because of the deranged liver function as well. So we sent off the AFP, that came back as 1,197. So I can hope you appreciate that's high. His CA99 is 75, that's high. And his CEA is 2. Now, when we've got a raised AFP, we decided to do imaging as well. I can stop here, or I could show you the images. It's up to you.
For the sake of time, why don't you just share the imaging with us, Pamandeep?
Perfect. Okay. So multiple. Okay, allow. Okay, so I'll start off with the MRI liver, actually. Sorry. I hope you can see that. Okay.
Yes.
So I'll just let you look at it and have your thoughts.
Yeah, what do you think, Sam?
Yeah, I'm seeing what looks to me to be multiple masses within the liver of different sizes, which to me look concerning for metastases. Yeah, I think you can consider other things. You could consider a primary hepatic malignancy. You can consider abscess, consider granuloma formation, but
Agreed.
I think this is likely metastases if I had to put my token down on something.
Agreed. Yeah, your multiple liver masses that are and DWI positive, meaning a restricted diffusion, is very concerning for that. I completely agree. Well, I think you're muted, Pamandeep. Sorry.
Sorry, I said that was great. And I'll now share the CTAP, which, to be honest, doesn't show anything different. Can you see that?
Yes, we can. Yeah. I didn't know Sam was a radiologist with reading MRIs of the liver so well. Anything to add, Sam?
I've actually never read an MRI of the liver before. It's just like those blobs don't look
Nice.
right.
Great job.
But CTs I've got a little more practice with. You can see, it looks like you can see some of those larger hepatic things a little less well on the CT. So I'm glad that we got to see the MRI. And then I do see this, is that some sort of extrahepatic mass that the arrow is pointing to? It looks like it's just anterior to the aorta. I'm wondering if that is, it's on the left, but I'm wondering if he's got maybe multiple sort of masses surrounding his blood vessels. It sounds like whatever was causing the right arm swelling was probably compressing his subclavian vessels, causing that. So I'm concerned about diffuse metastases in this patient.
Yeah, agreed. I'm also having a hard time finding what that anterior structure exactly is, what's going up and down. Just show you that I'm a pretend radiologist. I think the things that are in and around the aorta at the level of the liver and the stomach are potentially the esophagus or the IVC. Um, yeah, but I don't have the skill set to confidently determine what that structure is. But I see that it's like next to a narrow, you see a little like sort of air anterior of the aorta. I wonder if that's the esophagus. But I'm not sure, honestly. I'm really, yeah, that's the part that's unclear to me is what that soft tissue density that you pointed out, Sam. So we'll lean
Yeah,
on.
it's very irregular. So
Yeah.
maybe there's infiltration in the esophagus that's causing this.
Yeah. Yeah. Not sure what it is. Yeah.
I'm sure Pavandeep will
Yes.
tell us at some point.
I think you did very well. So very close to what it actually is. So I'll read the formal reports.
Yes,
Again,
please.
quite long, but so let's start with the CTAP, so the most recent image we've just seen. So they mentioned bilateral enlarged level 4 lymph nodes in the neck. On the right side, it's 4 centimeters. There's multiple lymph nodes elsewhere, so in the mediastinal aspect, but also lower paraesophageal lymph node noted, upper para-aortic lymph node, and aortal caval lymph nodes as well, and this mild splenomegaly. In terms of the MRI liver, they mentioned that there's supra and infradiaphragmatic lymphadenopathy and multiple hepatic focal lesions. Appearances are suggestive of metastases from an unknown primary. There's hepatic hilar ductal involvement by the dominant metastases at segment 8 with upstream mild to moderate biliary tree dilation. After that, we also did biopsy of that lymph node in the supraclavicular area that was seen on the Doppler. The report from that came back as follows. So 99% necrotic cells with few floating cells, which are being investigated, but likely insufficient for proper analysis. So I'll pause there, and then my last aliquot will reveal the clinching investigations and the diagnosis.
Probably what a sad and really tragic twist for this patient to have so much hidden disease. Yeah, Sam, what are you thinking so far?
Yeah, this all necrotic cells is concerning to me. That sounds to me highly consistent with hematologic malignancy. And then I think what I would do at this point with that information is send the TLS labs, and just see where we are with that, and then treat accordingly. And then I think making sure that we're having a really good discussion with this patient about what the prognosis is going to be, and consulting with our hematology and oncology colleagues about whether they can do anything to treat him. I don't quite have enough experience with this to say, but I'm gonna guess that this is likely not gonna be something that they can do anything other than palliative therapy for. Yeah, very sad.
It is. I think, whenever you have such an aggressive entity like this, which is really taking up a lot of space, lymph nodes, masses here and there, and has such necrotic features on biopsy, you do worry that this is a very aggressive tumor. And I think it really is an academic exercise to try to figure out what this is before a biopsy. But I think it has tremendous implications on how you biopsy, how the stubbornness with which you pursue this hypothesis. I think the challenge in real time is what tissue do you need and what tissue do you get? And I think that's a balance of the specificity of the biopsy with the ease of actually finding it. And so in some places you might do a PET CT guided biopsy, so on and so forth. But for the sake of time, I just emphasize that the aggressiveness of this process seems to be less compatible with something that's been smoldering for years. So I think you might wonder, is this new shortness of breath that he's experienced over the last few months completely independent of what is otherwise an MDS. So MDS is a common age-related condition. He might have had MDS, but now he has a new process. And how the new process might be affecting his cytopenias is through the entity called myeloptosis, where this process is now invading his bone marrow, causing his platelets to be almost unmeasurably low, and his white count and hemoglobin to be deeper and deeper. And so it might be just true and unrelated. And he has what's called a metastatic cancer to the bone marrow. I think it's interesting to say, to venture about the possibility that this is actually an acute on chronic process. And the hints that it might be acute on chronic are, of course, the long-standing refractory and difficult nature to articulate what this hematological element of this disease was, and the subtle hint that he has splenomegaly. So you might ask yourself, what does splenomegaly mean in this context? And unfortunately, most of the time, whenever you hear splenomegaly, you should think a liquid tumor. And when you think liquid tumor, you don't really, it's possible, but large hepatic masses are a little bit less likely. But it is possible for splenomegaly to actually represent extramedullary hematopoiesis from a solid cancer invading the bone marrow. So a small little teaching point is whenever you have splenomegaly plus cancer, you think leukemia or lymphoma. That rule is a good rule, but it can be broken by a metastatic solid tumor going to the bone marrow, infiltrating the bone marrow, and resulting in extramedullary hepatopoiesis. So I think the diagnostic test is to have a debate, multidisciplinary conference, figure out what to biopsy. And the question clinically is this really a rapidly progressive disease process that is independent of him having the possibility of age-related MDS, or can this all be tied in one full swoop that he has had a disease that has rapidly accelerated but been there for a long time? And the only thing that I can think of that is compatible with the latter hypothesis that is chronic myelomonocytic leukemia with transformation. And that's plausible, but it's rare. I think more likely this patient has two separate things going on and has developed a new solid cancer, which is likely very poorly differentiated. So what could we do next? I think your options are to do a bone marrow biopsy or to go after one of those liver lesions. And I think a bone marrow biopsy is probably where I would start, but I think it would be probably a multidisciplinary conversation. Mike, to you, Pavandeep, enlighten us, please.
So yeah, amazing thoughts. And we were actually in that sort of realm as well. We're not sure which one to biopsy. We did consult hematology. We did do an upper GI MDT. And hematology is like, no, liver should be biopsied. And then upper GI is like, no, we should go with the bone marrow. So we decided to go with both anyway. So the bone marrow biopsy shows morphological blast of more than 20%, 15% being CD34 plus and CD117 plus with myeloid progenitors. We then also did a lymph node biopsy of the supraclavicular area again because the previous one was insufficient. And so we said we'll just try again. And it says small proportion of the tumor cells show variable expression of HEP-PAR1, which is a metastatic carcinoma with an immunohistochemical profile that is suggestive of origin in primary liver tumor, so HCC. When they went to do the liver biopsy, unfortunately the patient was too unwell, and so they terminated the liver biopsy. But given those two, the diagnosis was made by the MDT to be acute myeloid leukemia plus metastatic high-grade HCC. In terms of the outcome for our patient, he deteriorated very rapidly on our ward. We moved him to the hematology ward as well. And the MDT said that we'll just palliate this patient with fast-track discharge to the nursing home. And a few months later, this patient passed away.
Wow. Amazing case, Pavandeep. Thank you so much. And just so rich with learning. Very, very sad outcome for this patient. I'm honestly a little surprised that it took him several months to pass away, and I hope that he was not suffering in that time. But wow, I'm blown away. You were absolutely right, Dr. Rabih, that he had two different things. This poor man.
Yeah, I mean, I think this is such a I think what Pavandeep is doing, I think, is taking tragedy and emphasize and translating it into learning, and that's what this space is about. Every patient who's been presented here has suffered in some way, shape, or form, some much more than others, and I can only imagine how much he's suffering, having been retired, living by himself, with very little social support, and having to handle all of this by himself. And having AML alone is devastating. Having ATC alone is devastating. And to have both synchronously is mind-blowing. And I think you might, from a medical perspective, wonder whether this is a true and unrelated, whether the probability of ATC and the probability of AML are true independent events. But I think it's a humble reminder potentially of the role of immune surveillance. And I think that to remind ourselves that our hematological system is meant to check in cancers, not just infections. And if a patient has a persistent hematological condition, they are always at risk of transforming to acute leukemia. That has been well documented. And what I'm going to try to learn and read more about, I'm curious if Pavandeep has any early insight into it, is what the risk of solid tumors are in people with chronic hematological conditions. But the way I would put this case together is I suspect he's had a lingering myeloid neoplasm, like MDS or the like, that transformed into AML, which has a horrible prognosis. And then wonder, especially in the absence of risk factors for cirrhosis, whether that hematological disarray led him to develop HCC. But I'm really curious to hear your insights, Bhavandi.
I just want to thank you. You actually like, produced more learning than I actually thought I would get. And I was just as curious with the hematologist, and I asked him the same question, like, is it possible to have one or the other? And his answer was initially quite confusing, but he mentioned this. Um, when a solid tumor like HCC spreads extensively, it can infiltrate the bone marrow, making blood counts and marrow appearance appear abnormal. And sometimes that can mimic leukemia or other bone marrow diseases. But in this case, it's possible to have two separate aggressive cancers. And when you have aggressive cancers, the cancer cells lose the typical markers of their tissue of origin, making it very hard to tell where they came from on biopsy. Fortunately for us, the biopsies were clear that there are two separate ones, and the other one didn't cause the other in that sense because of the histochemical makeup and the pathological makeup as well. But he did mention like Occam's razor, which I had no idea what that was. But he's like, at the end of the day, you know, we always try to have like a unifying diagnosis. We always try to have like put all our symptoms and make one diagnosis, but actually it's plausible to have two separate ones. And sometimes simplicity is key, and I think it was for this patient. But yeah, very unfortunate outcome, but lots to learn as a clinician.
Yeah, I think you're seeing a robust call in the chat to have you join us again and continue to teach us because this was a very special hour. The case itself is a very unique and rich one, but I think honestly the insight into who you are and what kind of physician you are is even more enlightening, and I really hope that you'll consider joining us more regularly. Um, yeah, a lot to reflect on. Sam has had to hop off for rounds, and I hope we'll give her a standing ovation in our hearts and minds for a really awesome job. Thank you so much, Simi, for scribing a really rich and complicated case. And now we'll hand the mic over to Gerardo for the teaching point.
Yeah, great. This was a very interesting case of a gentleman that presented with shortness of breath and palpitations. And we initially discussed between does it really represent a cardiac insult, or it can be high adrenergic tone. And also, one possibility initially was mentioned about a possible neuroendocrine tumor that could cause carcinoid syndrome if they bypass the liver and could present with the clinical presentation that we've seen about with diarrhea and vasomotor symptoms at the beginning. But then the discussion slowly turned to more of a hematologic topics, and we discussed the macrocytosis. And regarding macrocytosis, we have to remember that there are a variety of things that can cause it. It can be a metabolic derangement, it can be nutritional, and we have to think about the common causes, but also sneaky causes like copper. Also bone marrow problems, alcohol consumption, liver disease, or reticulocytosis. Um, Also, the immature platelets in the periphery can obviously mean that there is more peripheral consumption of platelets, and there are more platelets released to the in the blood, but it could also mean that the platelets are forced out by an infiltration of the bone marrow, and that could happen from myeloptysis, that like what it was mentioned. Also, there was a monocytosis in the labs of the patient, and we discussed it in the this particular finding in the context of this patient that has a pancytopenia. It was suspected of a pathologic monocytosis, and a differential diagnosis of CMML was mentioned. This monocytosis has a tendency to infiltrate, could clue towards chronic granulomatous infection or cancer infiltrating the bone marrow. Also, when we think about chronic macrocytosis, the differential could be MDS, or MDS triggering acute leukemia, or in this case, the acute leukemia that could be triggered by long-standing hematologic disorder, like it was mentioned in the at the end. And also, one thing that I think was very important was that since this patient was having an hematologic emergency, we should order the TLS labs for the tumor lysis syndrome, which is something that could worsen the clinical picture of this patient really rapidly. And well, just to end this, the myeloptysis, which is a bone marrow infiltration by cancer, can cause hepatosplenomegaly due to extramedullary hematopoiesis. But we have to keep in mind that it could also be from leukemia, lymphoma, and infiltrating the organs. And yeah, and also the last teaching point would be the long-standing hematologic disorders can trigger acute leukemia, although it wasn't the case in this case, which was two different entities happening at the same time. And well, although the outcome was negative, I think all we now have in our minds that this could be the presentation of in a patient, and we can sort of prevent the more morbid complications in the future. So I think this was a really rich case, and we learned a lot. And thank you so much.
Thanks to you, Gerardo, a future neurologist who understands medicine better than most. That was absolutely outstanding. Thank you again, Pamandeep, for a really, really special hour, and hope you have a great rest of your day, everyone. Bye.